Our bedtime story for tonight is written by Dr. Lauren E. Speidel, entitled Congenital Syphilis and the Prozone Phenomenon. Once upon a time, there was a premature male infant who had poor respiration and cyanosis. Cyanosis being the blood contains low oxygen levels, neonatal apnea, which meant a sudden cessation that lasts around 20 seconds, hepatosplenomegaly, which meant enlargement of the liver and spleen, and lastly, blueberry muffin rash. This is blueberry muffin rash on the infant's trunk. The rash appears due to bleeding or purpura, and the clusters of blood-producing cells are known as extramedullary erythropoiesis. Another thing that is observed in this case presentation is the Prozone phenomenon, wherein antibody levels can become too elevated to generate the complex of antibody-antigen, leading to a false negative result. The bad guy in this story is the bacteria Treponema pallidum. Like all spirochetes, it is made of periplasmic flagellar filaments, which are responsible for the deformation of the sacculus, resulting in the flat wave morphology. Also, T. pallidum has a long generation time of 30 to 33 hours and poorly handles desiccation, high temperatures, and oxygen tensions. This makes penicillin preparations preferred therapies for syphilis. Attached is a video from Stephens et al. Of spirochetes under the electron microscope. T. pallidum exhibits motility that consists of rapid rotation about its longitudinal axis, bending, flexing, and snapping about its full length. Treponemes are helically coiled, corkscrew-shaped, and varies with 6 to 15 micrometers long and 0.1 to 0.2 micrometers wide. They have an outer membrane which surrounds the periplasmic flagella, a peptidoglycan cytoplasmic membrane complex, and a protoplasmic cylinder. Multiplication is by binary transverse fission. For the classification and antigenic types, classification of the pathogenic treponemes is based primarily upon the clinical manifestations of the respective diseases they cause. Firstly, Treponema pallidum. As mentioned here in the case study, subspecies pallidum causes venereal syphilis. T. pallidum subspecies Pertinui causes yaws. T. pallidum subspecies endemicum causes endemic syphilis, and T. caritium causes pinta. Although treponemes lack classical lipopolysaccharide or endotoxins, they possess abundant lipoproteins which induce inflammatory processes. Based on studies, humans are the only source of treponemal infections. There are no known non-human reservoirs such as animals or vectors. Overall, inflammation is the primary expression of T. pallidum infection. The shortage of surface-exposed pumps enable multiplication of the bacteria to the lymphatic system and the bloodstream, thus making the infection rapidly systematic. The lack of surface antigenicity results to bacterial persistence, giving T. pallidum the name the stealth pathogen. Also, syphilis is named as the great imitator and the great mimicker, since it can manifest or mimic the symptoms of other infections. However, the mechanism of tissue damage and how the host defenses gain control over the bacterium are unidentified due to the inability to grow the bacteria in vitro. Syphilis cases are high among men who have sex with men, female workers and their male clients, imprisonment, multiple or unidentified sex partners, sexual activity related to illegal substance usage, internet sex partners, and other patterns in high-risk sexual works. Syphilis infection can be classified into two. The first is venereal syphilis, which is sexually transmitted. In this case, Transmission occurs through the actively infectious partner's exudate, wherein even as few as 10 organisms can cause infection. T. pallidum is also able to penetrate mucous membranes or through abrasions in the skin from spirochetes within dermis lesions of infected individuals. The next would be congenital syphilis, which is transmitted from mother to child. The risk of transmission to the fetus depends on the stage of maternal infection, which means that the longer the time the primary infection occurs before pregnancy, the more benign the rate and severity of the symptoms would be. Congenital syphilis transmission can occur across the placenta, in the breast milk if sores are present, also as well as direct contact during or after birth. Bacterial syphilis symptoms can happen through these stages, namely primary, secondary, latent or the hidden stage, as well as the last and most lethal one, which is tertiary. Listed in the table shown are the clinical presentation, duration, and other observations that are present on the different stages of syphilis. Primary canker is found in A, primary canker with rash in B, secondary syphilis with a pregnant woman in C, and palmar rash is shown in picture D. Another table is also shown to present the clinical presentations of congenital syphilis with the systems including dental, ear, cutaneous, skeletal, neurological, and ocular symptoms that is observed. Syphilis is diagnosed through non-treponemal or screening test and treponemal or confirmation test with specific serology. Non-treponemal tests are an indirect method that recognizes biomarkers that are released from the syphilis spirochete. Treponemal tests, on the other hand, search for antibodies that are a direct product of the infection, namely anti-treponemin IgG, IgM, IgA to a lower degree. And now that we know the basics of the infection, let us now go back to our baby. Initial findings include A. Torch syndrome or toxoplasmosis, others that include syphilis, rubella, cytomegalovirus, and herpes. Next is B. Congenital syphilis complications. And also B. Congenital syphilis complications. For the management of Torch syndrome, the baby was taken into the neonatal intensive care unit or NICU level 2. An umbilical venous catheter and a surfactant was delivered within the first 2 hours of the infant's life to help with respiration. High-frequency oscillation ventilation was also administered with inhaled nitric oxide with 20 ppm and inhaled helium oxygen with 50%. Initial echocardiogram findings were moderate pulmonary hypertension, and initial electrolyte panel resulted in elevated liver and creatinine. Let us now go over for the management of the congenital syphilis complications. So the baby was transferred to the neonatal intensive care unit or NICU level 4 due to the severity of the symptoms. Let us now have the timeline of events. So on day 7, serum T. pallidum IgG and IgM levels were collected and syphilis was confirmed as reactive. So to treat neurosyphilis, antibiotics were given for a 7-day course for clinical sepsis. Next, lumbar puncture was performed to gather cerebral spinal fluid, and tests show notably elevated protein and low glucose level, which means a manifestation of neurosyphilis. Antibiotics were continued for a 7-day course for clinical sepsis, and a 10-day course of aqueous penicillin G was administered to the infant. Acute neurosyphilis infection was exhibited with an RPR reflex titer of greater than 1:128. Additionally, long bone radiographs reveal loosened metaphyseal bands on all 4 extremities, both right and left, of the infant. Here are the long bone radiographs results. Picture A revealed the presence of metaphyseal bands found in the proximal humerus, distal radius, and ulna. Picture B reflects the long bone radiographs of the lower extremities. It can be seen that there are lucent metaphyseal bands with slight irregularity of the metaphysis of the proximal and distal femoral and tibia, and all results are consistent with congenital syphilis. For the outcome of the case study, on the day of life 8, the infant remained relatively stable from a respiratory, hemodynamic, and hematologic perspective and completed with his 10-day course of aqueous penicillin G. The infant was discharged on the day of life 38 and was highly advised with routine checkups for monitoring of clinical manifestations. After 2 months of age, the infant was tested and showed a titer of 1:32, comparatively lower than the initial value of 1:128, hereby confirming that the treatment for congenital syphilis was successful. Let us now have the discussion for our case study. So, blueberry muffin spot rash, hematosplenomegaly, and thrombocytopenia, or the abnormal low levels of platelets, were among the initial clinical findings of the infant. Although given a non-reactive maternal RPR at birth, diagnostic results of positive T. pallidum IgG and IgM, which meant positive syphilis enzyme immunoassay, and reactive cerebral spinal fluid VDRL, correlated with radiographic assessment, and also are consistent with congenital neurosyphilis. Due to the Prozone phenomenon, higher complications were observed in the infant. Disease management and prevention. So firstly, there is a need to develop a vaccine and to widen scientific knowledge for a better understanding of syphilis pathogenesis as well as the probable connection between syphilis and the human immunodeficiency virus or HIV. There is a need to repeat syphilis screening at 28 to 32 weeks of gestation during the 3rd trimester, also to test women with high risk for syphilis for those residing in cities with high syphilis morbidity. Also, conventional prenatal tests and present protocols must be re-evaluated using integrated non-treponemal and treponemal tests. Lastly, the Prozone phenomenon should be accounted for by neonatal care providers in all cases of pregnancy. Because syphilis is a sexually transmitted infection, preventative measures include proper latex condom use, male circumcision, restricting sex with infected individuals. Early detection can influence transmission rates and lower the risk of complications. Ultimately, the treatment of infected individuals still remains as the most practical manner of prevention. That concludes our storytelling for tonight. Again, this is Trisha C. Castellano from Bio 1110A. Thank you for listening and have a good night's sleep.